Good afternoon. Is everyone hearing well? That's good. I decided I would stand up because I'm about to have my post-lunch carbohydrate slump. And I was afraid if I sat at the table, I might sort of nod off in the middle of my own presentation, which would not be such a good thing. I'm here today to talk with you about our Mental Health Bridges project. And just by way of explanation, I'm a clinical and research psychologist and maintain a professor of psychiatry appointments at the Dartmouth Medical School and also at the UMass Medical School. So I come to this work with experience working with individuals with serious mental health conditions, largely in public sector mental health services. And that may explain a little bit to you about my role in this work. Is this the button? Wait. I was saying to Alexis in preparation for this meeting today that I suffer a little bit from post-traumatic technology disorder. For any of you who have given a presentation like this, witness poor Kate this morning, there's always something that goes wrong. So now I'm going to point it up there. It worked. Don't ask me why. You were talking about that magic wand, though, before. I think this is it. Our Mental Health Bridges project is funded by the National Library of Medicine, and that's our, other than that, we have no funders or conflicts. And this is a picture of my colleague, Len Levine, who's sitting in the back there, who's the Associate Director of the Countway Library at the Harvard Medical School, who is very much a part of our team in building the bridges. And by building the bridges, I should explain that our focus is on helping people with serious mental health conditions access information, useful, credible information about health conditions that are frequently comorbid with serious mental illness. We have a multidisciplinary team. I mentioned Len, who's with us today, Dr. Elaine Martin, who is the director of the Countway Library at the Harvard Medical School, Latina, a clinical psychologist, Allison, another information specialist, and myself. And so it's been actually quite an interesting and exciting project for me to partner with my health information specialist colleagues who are, in fact, certified, important people in the health information specialist world. Our goal for the project is to develop useful and usable tools, resources, and opportunities for individuals with serious mental health conditions to learn and practice health literacy skills in an accessible online space. And we are very much building this bridge as we are crossing it, hence the picture of Len struggling from one peak to the other. But my objectives today are to explain why we're doing the project, to provide the context for these design and implementation issues, and then to give you some data about what some of our research participants have suggested are important considerations in designing online spaces. I think it's pretty clear from this morning's presentations that people with mental health conditions, according to our latest data, comprise one of the largest health disparities groups in the world. 8 million people in the world die every year, primarily from natural causes, but comorbid to serious mental health conditions. And many of these natural causes, cardiovascular disease, diabetes, arise from things like smoking and obesity that are commonly comorbid for our people with serious mental health conditions. The irony, of course, is that many of these conditions are preventable. And so if people were provided access to and help to use good health information earlier on, we could perhaps be preventing some of these serious physical health complications. The majority of Americans get their health information online, myself included. I don't know about you. I know a lot of people watch those baking shows. I actually watch exercise programs online. Which doesn't mean I do the exercises, but I watch a lot of exercise programs. And that is actually one of the gaps that we're interested in, is how do you translate access to online information to actual changes in health behavior with hopeful consequences for reducing health disparities and improving health outcomes for people with serious mental health conditions. The majority of Americans do get their health information online. I don't know about you, but in this past year, I probably have spent the total of 60 minutes, and I'm in pretty good health, fortunately, 60 minutes with my primary care doc and thousands of hours online. And I can assure you that the same is true for people with serious mental health conditions, although we know that people with disabilities are less likely to go online and more likely to report being confused or challenged by using the internet. It is still the case in the most recent data that individuals, including those with serious mental health conditions like schizophrenia, bipolar disorder, have cell phones and use them daily, have computers and go online. Now, whether they are able to access and use the kinds of health information that we're hoping to promote is another question. But it is no longer the case, and in fact, I think this was a little bit of a stigmatizing assumption. It is no longer the case that we can believe that people with serious mental health conditions do not have smartphones or do not use the internet. This is my only brain diagram. And this is simply to help remind you about some of what we learned this morning about cognitive load, that in fact, or cognitive burden, that people with mental illnesses may in fact have cognitive impairments that get in the way of putting information together, of accessing information, putting information together, and then using it to make informed decisions, particularly about health care or health behavior. These, as were pointed out this morning, include memory difficulties, attention challenges, sometimes idiosyncratic thinking. And someone this morning talked about images used online. And people, particularly with different thought processes, can have different associations with icons that we routinely think, oh, well, that means I have an email, or that means that's where you go for help. So these things are the kinds of things that well-designed, well-tailored online resources can overcome. And we now have a bit of an evidence base on what that kind of design looks like. My colleague Armando Rotundi at the University of Pittsburgh and his colleagues have developed platform recommendations for platform, the flat explicit design model. The goal of which is to reduce page complexity, make navigation simple, and to improve the comprehensibility of information that's presented online. And my colleague John Naslund and his colleagues, many of whom have sprung from the Dartmouth Center for Technology and Behavioral Health, are putting together behavioral health theories with features and functions of online activities to replicate, to translate, and to apply behavioral health theory that works in interpersonal relationships to online interactive scenarios. As part of our research for the Mental Health Bridges project, we started by doing exploratory focus groups with individuals with SMI and also with, I'll call them health information specialists. We were really curious about people who considered themselves providers of health information, and these included medical school librarians, academic reference librarians, clinicians who routinely provided health information. And we conducted a total of 6 focus groups across the country to find out what these people thought about health information and online access for people with mental health conditions. Our individuals with mental illnesses, we recruited from inpatient units, from outpatient units, and from regional youth advisory groups. So that was youth and young adults with serious mental health conditions. So we spanned the age groups, all met criteria for serious mental illness. Some of them had had some college education, and all of them reported using their cell phones and the internet daily. What we heard from health professionals, health information specialists, was particularly interesting. They've actually made a shift too, much similar to the shift that we've made in healthcare. What they talk about, particularly those who are seasoned health information specialists, is that in the past, people would come into the library and they would establish a relationship with them. They would talk with them. They could sort of figure out what the person needed. They would have a conversation. They would trot around the stacks looking for information. And there was, in fact, a relationship, and oftentimes a trusting relationship built with the person who was providing you with information. Now, our health information specialists have shifted much more to where's the computer and how do I get my article online kind of approach. And so in many ways, their time and the quality of their relationship with their clients has been reduced, similar to the kinds of situations we were talking about this morning. But let me tell you what some of our findings were in brief. And if you look at these, you will see that they are completely consistent with what was described this morning about reducing cognitive burden and overcoming impairments in in-person relationships. The same is true online, but let me tell you some maybe not so startling facts. Number one, if people want information online, our people with serious mental health conditions, they Google it. And whatever comes up first or second, oftentimes that's where they go. And so if you've ever randomly Googled something like, my dog has tics, the first three things that come up are ads for Dr. Joe Blow's tick medication or whatever. And so oftentimes people are initially directed to sites that may not be credible, reasonable sources of information. They often stick with the site they previously found helpful. Sometimes they look for names with authority like .gov. Oftentimes they go to sites that look familiar, and they specifically mentioned Wikipedia because lots of people know Wikipedia, and it has a consistent format. So every time you go to Wikipedia, it looks the same. And there was something about consistent format that helped people feel comfortable. Whether or not you believe that things on Wikipedia are credible or true is another question. They reported going to professional sites like the American Heart Association site or, a site that we would think would be a credible professional site for information about their health condition. But for information about a personal experience, like I have a really dry mouth, I think it's my medication, or I'm tired all the time, do you think if I stopped taking my antidepressant, I could get up in the morning and feed my kid breakfast? They go to social media and online forum where they talk with people with similar experiences, they think and hope, about how to manage those kinds of situations. So for general information, they go to the professional sites, but for real day-to-day coping, how can I manage this, they go to social media, e.g. Facebook. There was mixed feeling about social media amongst our focus group participants. While many indicated that social media and interactivity could stimulate support behavior change, validate experiences, sometimes people did feel a little insecure. And in fact, it was the information specialists, not the individuals with serious mental health conditions, who were most concerned about monitoring or supervision in social media sites. Design recommendations. I love these recommendations. In fact, I try now to do my own slides using these recommendations, and I have to confess that some of the slides this morning were very complicated. But people tend to like simple, sort of well-positioned information with not too many columns. Interestingly, people reported a lot of trouble, and think about this, a lot of trouble with navigating columns across the page or up and down the page. Do I read all the way down the column and then go back up, or do I go across? If your organization, NAMI for example, has a website with many columns, you're going to run into trouble. People who are looking for information on your site, and I don't mean to pick on you, but I was thinking of a well-regarded advocacy organization. People will have trouble finding access to the wonderful resources you may offer on your site. I myself went to PubMed and tried to find information about aneurysm. I picked the first thing that came to the top of the list. It seemed like it might be a cardiovascular thing. It took me 7 clicks through 7 layers and off the site into 2 other sites to find a definition of aneurysm. So even for people like you and me who may have trouble with attention or distraction or memory, navigating to find appropriate health information can be challenging. Actually, as someone was talking this morning about memory, it occurred to me that I would do a quick survey here. Is there anyone in this room who can honestly say that they can remember all of their accounts and passwords for all of those accounts? Raise your hand. Well, one person in the back. I don't believe you. So, this issue of memory and navigation and sites, paying a bill online is a challenge that my 97-year-old father seems to have mastered. But every once in a while, he loses track of his password. Seriously, good design recommendations for people with cognitive deficits or impairments are good design recommendations probably for all of us. In terms of content, clear, concise language, simple language. What people really wanted was practical suggestions. If your Department of Psychiatry can give people practical suggestions on how to cope with the daily challenge of getting out of bed in the morning if you're depressed, people would really appreciate that information. They want to know how to get by in daily life. And I know that you don't have time in your 15-minute internal medicine visits to give people advice on how to manage getting up in the morning to feed their kid breakfast. So there is, I think, incredible opportunity and great value in thinking about exploiting some of these technology-based and online-based solutions to help the people we work with. Things to avoid, that's simple. It's the same kinds of things you would want to avoid in speaking, using a lot of acronyms. Clickbait sites, those things that drop down, and someone told me this morning George Clooney was in an accident, just saying, those things that drop down and sort of lure you into other places because you're really interested in George Clooney. I agree. Google ads, pop-ups, paid ads, people find those confusing, especially when they're down the side of an otherwise credible site. And sometimes people click on those and get into places that we would not necessarily want them to get to for credible, empirically based information. Finally, we're working with this pathways model of believing that access to good health information would somehow lead to changes in health behavior, which would somehow reduce disparities and lead to better health and wellness. I know there are some gaps there in that pathway and we talked about some of those this morning too, the research gaps in understanding the bridges between having access to good information and employing that good information to do better and feel better. But that's the challenge we're tackling. So thanks for your time. And contact us for sure if you want any more information. And just to note that I didn't intend any copyright infringement with any of these images. Thank you.